Hi everyone, my name is Dr. Anyeji. I am a psychiatrist and I specialize in interventional psychiatry, which is a field that basically looks at a few modalities, including electroconvulsive therapy, ketamine or esketamine, and transcranial magnetic stimulation. I personally specialize in electroconvulsive therapy or ECT and ketamine. And today I wanted to talk about ketamine just to give a brief introduction to what ketamine is. Now, I should say that this discussion is not meant to be clinical advice. It's meant to be purely educational. It's based on my clinical experience and on my interpretation of the literature itself. And so, without further ado, let us get started. So, what is ketamine used for? Well, it's mainly used for depression and specifically treatment-resistant depression. Now, we're going to go into this in a subsequent slide, but there are really two main ways in which ketamine is delivered clinically. There is esketamine and then there is the IV ketamine. Esketamine currently has FDA approval for treatment-resistant depression, and it's approved specifically as an augmenting agent to an existing antidepressant medication. So it's used for treatment-resistant depression. What is treatment-resistant depression? This is essentially a depressive episode that has not been responsive to at least two antidepressant trials. So if a patient has had two adequate trials, at least two adequate trials of antidepressant medications, and there's been no response, excuse me, then they are deemed to be treatment resistant. Now, many insurance companies would actually want more than two trials. They would want sometimes up to four antidepressant trials because in many of the studies, the average number of antidepressants were actually four. All right. Now, ketamine has been shown to be effective in a host of other disorders beyond depression, such as PTSD, OCD, actually substance use disorder, bipolar depression. But the studies in these other conditions are not yet robust enough to justify FDA approval. So right now, clinically, esketamine is FDA approved for treatment-resistant depression, specifically to be used as an augmenting agent to an existing antidepressant medication. And it's also approved for depression with suicidal thoughts or suicidal behaviors. Because that's the other thing with esketamine. It seems to really help with suicidality. Okay. Now, when I talk to patients about ketamine, I usually say there are two kinds of ketamine molecules. There's a left-sided version, there's a right-sided version. The left-sided version is called esketamine. The right-sided version is called R-ketamine. The left-sided version, because it's easily absorbed through your mucous membrane, could be delivered as an intranasal spray. So hence, esketamine is usually delivered as a intranasal spray. Clinically, the other way we deliver ketamine is intravenously, and the IV ketamine version is a combination of the left and the right side. Okay. How does ketamine work? Well, ketamine binds to the NMDA receptor, and just going to really quickly on the NMDA receptor, we're going to go into a little more detail than you might need. The NMDA receptor basically is receptive to glutamate, which is the major excitatory neurotransmitter in your nervous system. And glutamate is complex. So glutamate requires a bunch of factors for it to be active. It requires glycine to be present on the receptor for it to take effect. And also, because the NMDA receptor is blocked by magnesium, there's an additional requirement for a depolarization, which is just like an electrical potential that kicks off the magnesium and therefore activates the receptor. So what ketamine does is that, and just take a step back, when magnesium is kicked off, the channel is basically open, and then you could have an influx of ions, sodium and calcium. So ketamine is interesting in that ketamine is like some other compound called PCP. And what ketamine does is that ketamine actually blocks the NMDA receptor and prevents its activation. So that's its immediate action at the receptor level. So we're going to go into some more detail here. So what I tell patients when I try to explain how ketamine works is that I say ketamine facilitates something called synaptogenesis. Essentially, ketamine helps your brain cells form better connections in certain parts of your brain. And one unique thing about ketamine that sets it apart from many other classical antidepressants is that ketamine acts very quickly. So its effects, some studies would suggest, occur on the order of minutes, hours, certainly sometimes within the very first few treatments. It might take longer for some patients, but it's a very fast acting antidepressant medication. So it facilitates synaptogenesis. Now, more specifically, what ketamine does that, like mentioned, it blocks the NMDA receptors. And because it's blocking the NMDA receptors are typically excitatory, the um, neurons that are downstream from the NMDA receptors are GABAergic neurons. Now, GABAergic neurons are typically inhibitory. And so if you block excitation of inhibitory neurons, you would release inhibition of whatever is downstream from the GABA neurons. So essentially, the GABA neurons that are inhibitory are connected to glutamate neurons. Because you're removing the GABA inhibition, you have a glutamate surge. And this then goes on to activate other AMPA receptors. There's some complexity here, but it targets AMPA receptors, which is a kind of glutamate receptors. And downstream, what this leads to is that it activates certain pathways. One of them is called the mTOR pathway. It also increases this factor called brain-derived neurotrophic factor, BDNF. And the ultimate effect of all of these processes is synaptogenesis, in which your brain cells can then form better connections. Some other ideas about how ketamine works is that it reduces the activity of this part of your brain called the subgenual anterior cingulate cortex. It's an important region in your brain. The subgenual anterior cingulate cortex actually is involved in depression, and in depression has been shown to be very hyperactive. Actually, it's believed to be a biomarker for, say, TMS, and some deep brain stimulation procedures target that part of your brain. Some may even say that this region, the subgenual anterior cingulate cortex, is the depression center. In studies, when this part of the brain is stimulated, people report feelings of sadness. So ketamine seems to reduce the activity of the subgenual anterior cingulate cortex. And there are some ideas that ketamine might be involved in the opioid system. Um, we're still trying to really delineate the mechanism of action of ketamine, but it seems like as though ketamine works in concert with mu receptors, or rather opioid receptors, and that activation of opioid receptors allows ketamine to mediate its function. This is just an idea of how ketamine works. The summary, though, is that ketamine allows your brain cells to form better connections in a process called synaptogenesis, and this sometimes occurs pretty quickly. So when talking about ketamine, it's important to understand what I see as the structure of major depressive disorder. So depression is a very interesting clinical phenomenon. We think of depression as occurring in episodes, and it's a very well-defined episode: depressed mood, reduced interest, or it's called anhedonia, and other symptoms as well: difficulties with sleep, difficulties with appetite, concentration difficulties, suicidality, lasting for at least 2 weeks. That's a depressive episode. Now, what we find is that when people have that episode of depression, which, if untreated, could last months, 6 months, or even longer, when people have that depressive episode, there is a 50% chance of another episode. If you've had more than one depressive episode, it's 80-something% chance of another one. And the more depressive episodes you've had, the more likely you are to have an episode in the future. So depression is called a recurrent episodic illness. Because in a sense, it's chronic, and you don't ever really cure it or get rid of it. If you've had it previously, depending on how many times and how severe, there's a very high chance that you're going to have it in the future. And understanding the structure of depression across the life should inform one's attitude or approach towards treating depression. And this is very important when we start thinking about ketamine and how to apply ketamine in the clinic. So there's a high risk of relapse without maintenance treatment. And this is a very important consideration, and patients should appreciate this point. Um, we don't quite talk about this in the rest of the this presentation, but I should say that ketamine actually is not believed to be a complete replacement of your other treatment um, plans you have in place, right? And once again, it's important to keep in mind that with depression, if one has had multiple episodes, there's always a risk of a relapse, and that should inform treatment planning. And once again, with ketamine, it is not meant to replace your other treatment plans. You should still go to therapy if you're seeing a therapist. You should still work with your outpatient psychiatrist in terms of medication management, still engage in your hobbies. If you're a social person and you enjoy hanging out with people, still keep doing that. If you're more a contemplative, reflective type, you love reading, keep doing that. Exercise still, good diet. I want to really watch your diet, sleep. So you still want to keep everything else in place in terms of your therapy, other medications, hobbies, sleep, diet, and exercise, because ketamine is just one part of your overall treatment, and everything works together to give the best outcome and to help you continue to sustain your response and hopefully remission. So let's go into IV ketamine, one kind of ketamine. This is a ketamine that's a mixture of the left and right side. So the dosing, now this is based on studies. You start at 0.5 milligrams per kg. So it's a weight-based kind of dosing. Typically in our clinic, you could up titrate it up to like 1 milligrams per kg. Some clinics go higher than that. It's infused over 40 minutes. And typically it could be administered once, twice, 3 times a week over a period of 2 to 4 weeks. Usually, the the acute treatment course involves 6 to 8 treatments in which you assess if there's any response or how effective it is, like I just mentioned. And so you could assess response after 1 or 2 treatments, after 1 or 2 or 3 treatments. Typically with ketamine, like we mentioned, the efficacy, it acts pretty quickly. So you should know, quite frankly, within the first few treatments. And if there's some response, then you could keep going up until treatment number 6, 7, 8. The tricky thing about IV ketamine is that it is not yet currently covered by insurance. And so for the most part, many insurances do not cover it. So it's an out-of-pocket cost. So a lot of the decision making, in addition to efficacy and side effects, is also finances as well too. If after a few treatments, 3, 4 treatments, there is no response, there could be some response if you went all the way to 6 or 8. But the response to the very first few treatments could be predictive. And so one could ask the question, if after 3 or 4 treatments there's no response, if one needs to keep going, getting additional treatment. Like I mentioned, you could respond very quickly. And usually when you get a treatment, the effects peak within the first 2 hours. I usually tell patients like 90 minutes. So you would feel some of the dissociative experiences, and we're going to talk about that. That's the one thing we haven't yet mentioned, that ketamine is known as a dissociative agent. And that's important when we're talking about the possible adverse effects. All right. I like saying dosing matters with ketamine. When I teach the residents, I point this out. And because ketamine has multiple uses, it's known in a multiplicity of settings. So actually, anesthesiologists use ketamine as an anesthetic agent. And it seemed to have been the case of at least one of the neuroscientific models of psychosis comes from understanding PCP, that is like ketamine, because it blocks the NMDA receptors and causes downstream processes that leads to activation of a pathway that's implicated in psychosis. But my understanding is that the psychotomimetic effect of ketamine tends to be at higher doses. And the anesthetic effects are also at higher doses. And the antidepressant effects, the effects of interest for us, at sub-anesthetic doses. So depending on how you dose it, you could start getting different effects of ketamine. Let's talk about esketamine. So we mentioned that IV ketamine is the combination of the left and the right side. Esketamine is a left-sided version. Esketamine is the kind of ketamine that is FDA approved for treatment-resistant depression. It's the intranasal spray. It's also called Spravato. So we'll talk about the treatment schedule and logistics. So what we do is there's an induction phase. So within the very first month, the way treatment is applied is you apply 2 treatments per week for 1 month. And they are really two dosing. There's 56 milligrams and 84 milligrams. Some of the studies suggest that 56 milligrams is roughly equivalent to that 0.5 mg per kg for the IV ketamine. So typically, the very first treatment, you give the patient 56 milligrams, see how they do. They tolerate that well. Second treatment, you could go up to 84 milligrams. So after the very first month of 2 treatments per week for 1 month, you assess to see if there's any improvement, if there is some response, that is the patient is showing some appreciable improvements in depressive symptoms, then you could proceed to the second phase in maintenance phase, which is 1 treatment per week for the next month. And at this time, you're probably likely going to be at 84 milligrams. Once again, you assess response to the very first 56 milligrams of esketamine. If they're okay with that, you could go up to 84 milligrams as quickly as a second treatment. So in the second month, where you do 1 treatment per week for 1 month, you assess them again. And if they continue to sustain a response, then you could go to the final, not the final, but the next stage, which you could continue the weekly treatment of esketamine at 84 milligrams or 56 milligrams, or you could go to every other week or every month. It all depends on what schedule works for the patient. At this point, this is all dependent on things like side effects. Is it been effective? Patient logistics. And then you could determine the treatment frequency that works for the patient. And patients often ask me, well, do I stop? When do I stop? And there is no set expiry date for esketamine. This goes back to the point about the maintenance we discussed. From what we understand about depression, it's a recurrent episodic illness. And in order to sustain remission, we have to have that maintenance plan. And also, very importantly, I think we're going to look at this in one of the future slides. There's a very high relapse rate on ketamine. That is, if you treat patients with ketamine and you stop treatment, there's a high chance that they would relapse. And what the study seems to suggest is that patients might relapse within 3 weeks. Not everyone, some patients. And this is why we have this maintenance plan in which we are continually assessing the patient, seeing how they do. And the patient could always stop treatment at any time they want to stop treatment. Or if there's some side effects, or if they're having difficulty tolerating the treatment, you could stop treatment. If the effect plateaus, because we see that sometimes where after a certain period of time, the patient sort of like gets too used to the medication. They almost build a tolerance in a sense to the medication. Okay. Let's just look at some data. So with ketamine, we've discussed as a rapid alleviation of depressive symptoms and suicidality. Response rates are high, 70%. That's pretty high actually for psychiatry. And like we mentioned, the effects could last for 2 weeks. The median time to relapse after last dose was 18 days. So there's a very high relapse rate with ketamine. And that's why there is a discussion about the maintenance treatment style. And it seems to be the case that ketamine plus some antidepressant like an SSRI enhances the effectiveness of the SSRI. Very important discussion on the side effects. These are just a list of side effects. We're going to try to go into each of them in some more detail. When we go into these side effects, I talk about most of them, but I don't think I talk about nausea or salivation. Nausea is very common in ketamine. And what we do typically is we could give the patient Zofran or some antiemetic agent to help them tolerate the treatment. For esketamine, we also advise patients to don't have anything by mouth 2 hours prior to treatment. So the very first big side effect is dissociation. Ketamine is a dissociative agent. And this is an important one. So what is dissociation really? So dissociation is an altered sense of reality. It could come in the guise of perceptual disturbance, derealization, or depersonalization. Or derealization means that you almost feel like as though you're in a dream. The external world feels unreal. Depersonalization almost feels like as though you're kind of like out of yourself, out of your body. People's dissociative experience differs. It's different for different people. That's what I tell patients. You cannot know in advance how someone is going to react. Perceptual disturbance means that there is some alterations in your perception. It could be that objects could appear to be larger or smaller than they actually are. It could be that you have feel sensations on your skin. You could be more sensitive to sounds. So there are all kinds of sensory distortions you might experience. The overwhelming feedback I get from patients is that this is not a scary experience. The majority of people tolerate it. It does not feel negative. It doesn't feel overwhelmingly negative. Some patients actually even like the experience. So usually the feedback I get about the dissociation is that it's a neutral to positive experience, usually not scary. But there are some cases where a patient has an extreme, or rather, a patient feels very overwhelmed by negative emotions, and those could be scary. It's called bad trips. In my 2 to 3 years of working in the ketamine clinic, I've seen this happen maybe 2 or 3 times. It's not as common, it's a possibility, but the main point is that the vast majority of patients who experience some dissociation tolerate the experience well. Um, Dissociation tends to be common, especially with IV ketamine, occurred in 72% of studies versus 36% in non-IV ketamine studies. And it seems to be the case that with each subsequent treatment, the depth and intensity of dissociation decreases. And usually this dissociative experience peaks within 40 minutes and resolves within 1 to 2 hours. Does dissociation mean that you're getting an antidepressant effect? A lot of patients feel that way. They seem to correlate their dissociative experience with antidepressant effect of ketamine, but the studies seem to suggest that maybe not necessarily. Maybe dissociative effects are not necessarily related to the antidepressant effect. That is, whether you dissociate or not does not mean that ketamine is not working. So I always tell patients to not be worried about how they feel during treatment, that they should just go with the experience. It doesn't mean that you're not actually getting the antidepressant effect. And that what we still look at is how they are not just within treatment, but how they are outside treatment, how they are the days succeeding treatment. So if a patient isn't getting the dissociative experience they thought they were going to get, that does not necessarily mean that the esketamine is not being effective. Okay. So ketamine could also exacerbate psychosis. It's called psychotomimetic effect. I think this occurs at higher doses. And psychosis is not the same as dissociation. With psychosis, you have the presence of a perception, if you will, without any external stimuli. So, for instance, this would be hearing voices when no one is talking, seeing things when there's actually no physical object in the environment, things like that. Psychosis could also include like delusions, where you feel like as though the FBI is out to get you, or an alien is about to abduct you. Um, so that's the sense. This is different from dissociation, and in some ways might be more serious. And it's also more likely in people with a primary psychotic disorder, like people with, say, schizophrenia. We'll talk about some of the contraindications, that is, things that if a patient has, you don't want to do ketamine. One of those things is a primary psychotic disorder, like schizophrenia. So you want to avoid ketamine in patients that have an underlying psychotic disorder. The one thing about psychosis also is that it is more likely with IV ketamine, maybe not so much with esketamine, and it's not as common. It's actually a rare side effect. Does ketamine affect cognition? Doesn't seem to be the case. The studies do not suggest that. The common neurological side effects are things like dizziness, drowsiness, and maybe lightheadedness. This is actually these other symptoms, the dizziness, the lightheadedness might be a little bit more common, but it tends to peak during treatment within the first 2 hours. And what I notice is what patients tell me is that over the course of the day, it significantly improves. Ketamine might actually have effects on your heart. So it could increase heart rate and blood pressure. This might occur in 10 to 50% of patients. It's observed usually within the first 50 minutes and resolves within a few hours. Um, usually it's asymptomatic. So the patients could have mild elevations in blood pressure and heart rate without any, significant symptoms. And a very small percentage of people who might require an antihypertensive. Um, at least in my experience, we don't have too many cases of people with blood pressures going into the 180s of systolics and 100s of diastolics. Ketamine might have effects on your urinary system, um, and this seems to be dose dependent. This is also seems to be more likely with IV ketamine. So it's things like peeing, increased frequency of peeing at night, painful, like blood in the urine, painful urination, feeling like as though you really have to go pee. Um, this could this could actually indicate something called urethral cystitis, that is inflammation of the bladder. It's another rare side effect. The studies seem to suggest it's not that common with esketamine. And if a patient starts reporting these symptoms, that would be a good hint to stop treatment. Ketamine is a Schedule 3 drug. So what's a Schedule 3 drug? The schedule basically represents the degree to which a drug can be abused or addictive. Schedule 1 are highly addictive substances like fentanyl, heroin. Schedule 2 are slightly less addictive substances like stimulant medications, Adderall, Ritalin. Ketamine is Schedule 3. So the degree of addictiveness decreases as you go from Schedule 1 to like Schedule 5. So ketamine is somewhere in between. There's been some concerns that ketamine might, patients might have this increased liking for ketamine, which might indicate the development of an addiction. But there isn't any evidence really that ketamine per se causes or increases the risk of substance use disorders. Some things that, are so like a big no-no for ketamine are like significantly elevated blood pressure. So if a patient's blood pressure is not under control, that would be a big no-no. If there's been some recent bleeding in the brain, that's huge because ketamine increases blood pressure. You don't want to cause a hemorrhagic stroke. History of seizures, ketamine actually lowers the seizure threshold. History of psychosis. So because ketamine works on the NMDA receptor system, it actually, through that mechanism, could cause psychosis. So if someone already has psychosis, you probably don't want to do ketamine. If someone has had a previous hypersensitivity to ketamine, you probably don't want to get them ketamine. Ketamine doesn't work in pregnancy as well. And as we mentioned, history of psychosis or mania. And then there's some other conditions you want to just keep an eye out for. Porphyria is a kind of blood disorder. A history of substances, you want to just keep an eye out for that. If there's a known heart disease, you want to make sure their blood pressure is under control, that there's no active heart problems. Glaucoma or elevated intraocular pressure, ketamine could make that worse. If there's any thyroid disease, you want to keep an eye on that. Make sure that's under control. Same thing for lung disease and liver disease. If there's any aneurysm, like that is a blood vessel that might burst, you want to definitely consult with a neurosurgeon and neurologist to make sure it's okay to proceed. And we talked about cardiovascular disease. So how do we prepare for ketamine? The concept of mindset and setting is very important. So the mindset is basically the mental framework with which you go into treatment. And what we find is that the less anxious patients are, the better, or rather, it seems to be the more effective the treatment is going to be. So I try to advise patients to try to be as calm as you can, try to minimize anxiety as best as you can. This is where things like being comfortable clothing could come with your earphones, eye masks to minimize external stimulation. If you want to meditate, that keeps you more calm, that works. And the setting is the ideal setting would be a quiet space where the patient is by themselves. There isn't much noise. There isn't much distraction. They could just really focus on treatment. The setting cannot always be controlled because sometimes they're done in a hospital space. And for some patients, that may be a little bit triggering, but these are just the limitations of specific practices. No food or drinks 2 hours before treatment. This is requirement for esketamine. It also helps minimize nausea. Um, you have to be at the treatment center uh, for esketamine. You have to be there for at least 2 hours. And you cannot operate heavy machinery on the day of treatment. Definitely no driving as well. Patients often ask me when I'm getting treatment, either during the IV ketamine infusion or after I've just received the intranasal spray. Is there something I should be thinking about? Is there an experience I should be looking for? My response is there is no right or wrong way to be in ketamine, and there is no particular experience you're looking for. The most important thing I tell patients is to have an open mind and to be almost flexible in your expectations. That is, you go with the treatment as it comes, and you do not have any rigid expectation. That is, you're not trying to have a particular kind of experience. Because once again, there's no right or wrong way to be in ketamine treatment. There is also um, different responses by different people. So different people have different dissociative experiences. Some people it's mild. Some people it's deep and spiritual. Some people they just have mild sense perceptual disturbances. So it really there's a lot of variability here. And so I don't want patients being anxious or worried about how they are feeling exactly during treatment. That they should just be in the moment, stay with the treatment, keep an open mind, and be flexible in the expectations. Because, as I try to remind patients, the studies do not necessarily suggest that the dissociative experience itself means that the treatment has been not successful or successful. And so they should maintain a separation in their mind between the dissociative effect and the antidepressant effect. That's how I try to direct and guide patients who are about to start ketamine treatment. All right, this is just a very brief overview of ketamine. It's not completely exhaustive, but that's just meant to be an introduction. And I hope you found this video helpful. Thank you for watching.